So good morning, everyone. My name is Rich Copp. I'm the Vice President of Communications at Partners Healthcare. And on behalf of Partners Healthcare, I'd like to welcome everyone to Boston for what is really one of the signature events here at Partners Healthcare. For those of you out of town, by a show of hands, how many are from out of town? Yeah, I'm going to apologize for the weather here in New England. We don't normally have 70-something degree days in late October, so I'm hoping that tomorrow we have a clean, crisp fall day for you on tap. My job here this morning is to introduce someone who's a pioneer in the design and utilization of healthcare data and communications. Thomas Goetz is the co-founder and CEO of Iodine, which I think is a company well known to many of us in the room. It's a San Francisco digital health company that's helping to improve the patient experience through the use of demographics and patient preferences. One of the things, if you haven't seen, a few years ago, Thomas did a TED Talk that's been viewed more than 500,000 times. And in it, among other things, I really strongly suggest you check it out. Among other things, he actually has the temerity to suggest that patients can actually benefit from engaging in their own health information when it's presented in an accessible way. And that, by engaging patients with their own information, you can actually move beyond compliance and actually empower patients to improve their own lives. Thomas is also, his resume is very impressive. He's also served as the executive editor of Wired magazine. Under his leadership, he won dozens of national awards for that publication. And today, there's a new book out. There'll be a book signing just a little bit later. And the book called The Remedy, Robert Koch, Arthur. It's called The Remedy, Robert Koch, Arthur Conan Doyle, and the Quest to Cure Tuberculosis was actually named a best book by Amazon for 2014. On top of all this, he holds a Master's of Public Health from the University of California, Berkeley, a Master's in American Literature from the University of Virginia, and he's a New England guy, graduated from Bates College. And on top of all that, he plays the cello. So please, with that, give me a warm welcome for Thomas Goetz, please.
That was great. Good morning. This is like a TED circle. So when I started thinking about this talk, I was thinking about, talking to Joe about it, it was all about the new presidential announcement about precision medicine initiative was kicking off, and I thought, oh, that's going to be somewhat relevant. And so I'll get to that. But what I wanted to start with was actually a talk that is miles away from kind of a high-tech audience, even though it's a story that takes place in San Francisco. It's about city buses in San Francisco. Hold on to your seats. So this is a story from one of my heroes in healthcare and behavioral health, Len Syme, out of University of California, Berkeley. And in the 1980s, Len and some of his team at Berkeley realized that the bus drivers in San Francisco had a kind of systemic problem. They were getting, as they got older, their blood pressure was going up. In fact, 90% of the drivers over 60 had hypertension. So they wanted to create an intervention and fix that. So they went and got a grant, and that's what they set out to do. What they realized, though, was that they didn't just have hypertension. All these bus drivers also had chronic lower back pain. So they realized they had to increase the scope of their intervention, and so they were looking at the back pain. They also then came up with all these gastrointestinal problems, and it went back and back and back. And what they realized was that there was a kind of systemic problem that went beyond the health of these bus drivers as we define health, because what was happening was the route itself, the route that these bus drivers would drive every day, was a little bit gamed against them. The schedule was mapped so that you could really never hit your marks on time. And so the drivers were always under stress. They were always late. The passengers were always mad at them. And because they were always late, they would not take their breaks. They would they would kind of pass off on their breaks so they would be able to keep on schedule. And they would end up kind of dashing into McDonald's when they could to get a bite of food. And at the end of the day, they were stressed out, and they would go to the bar. And so they had high levels of alcoholism. So this is what they discovered. So then they had to figure out the problem. So how could they figure it out? So they went back to the managers of the San Francisco MTA, and they realized that there was actually they wanted to fix the schedule, but there was an institutional problem that the drivers or the managers were oftentimes former drivers, and they didn't want to budge the schedule because they had gone through the same process themselves, right? So if they could do it, so could these new drivers or the other drivers. And the other thing they realized is that the managers had some sort of resentment towards the drivers because this was always unhealthy, the drivers were always calling in sick, and a fully 1/3 of their budget was going to short-term replacement drivers, right? So they were spending all this replacement drivers because the drivers were always calling in sick. So they didn't really have any incentive to fix the problem. So when you start unpacking that, it looks like this. It was not just hypertension, what they thought they were dealing with. It was all of these other problems. And the further back you got, the messier it got, right? The more complicated it got, the more they were burrowing into the real lives of people, the more they were burrowing into the kind of messy reality of life. How do you fix that? Well, in this sense, it's a very analog problem. And what I want to talk about today is the opportunity to maybe take some digital initiatives that might address these kind of problems. Because when we start looking at problems like this, when we look at it as hypertension, we think, oh, medicine can take care of that. That's what medicine is for. And we expect it to work. When we give people a medicine, when we prescribe them a medicine, say, we have the diagnosis, we know what the treatment is, go do this treatment. People have an expectation that it's going to work. And then it doesn't, right? You have this massive failure rate in medicine, and we all live with it. We all know about it. We're all hammering at it, but it's still there. And for people, for the individuals, it can be incredibly frustrating because, like those bus drivers, there's always something behind it. There's always something that medicine just doesn't quite get. And what I want to suggest is that we could do a little better about this. The status quo, the way I kind of define it, is it's kind of hit or miss medicine, and trial and error is the kind of norm, which is to say failure for two reasons. One, because, again, thinking about the treatments, about the kind of medication therapy side of it, a lot of the treatments just don't work, right? And we know that. We know that there are drugs that we have to go through the process of trial and error. But for people, again, this is frustrating. For people, this is misery. For people, this is a slog. We need to fix this through learning, through listening to people as they go through their experience. Experience, I maintain, is the key. So when we talk about precision medicine, we think about genomes and metabolomes and proteomes, but there's this other thing which is not living in our corpuscles, but which is not measured by microscopes, but is in fact more adequately measured by microphones, by asking people, how are you doing? What are your preferences? What are your tolerances? What are your experiences? Those are the things that we can map to right now, the low-hanging fruit, if you will, of precision medicine. What used to be called personalized medicine, after all, until we realized we had worn out that chestnut. But think about it. Experience could personalize medicine. Experience could be the key here. Listening to people might be the key. So I want to unpack this in three little strategies or philosophies or frameworks. The first is to measure the mess. The first is to engage with the complexity of life and complexity of health as it exists, which is a daunting thing. In fact, if you think about the kind of the audacity of that statement, it in some sense is contradictory to the entire way we approach medicine, right? We create randomized controlled trials, after all, because they are an artificial reality that we can understand. We create this kind of apparatus of medicine because we are limiting the variables. Life is messy. We don't want to go there, but we have to, because that's where people live. We have to measure it. People do not live in the Mayo Clinic or Brigham and Women's or whatever your citadels of medicine are. And these are amazing citadels, right? They are amazing kind of triumphs of science that we have created. They do amazing work, but these are not where people live. People do not live here. They live here, right? So this is a map or a grid of all the hours in a year. So it's about 8,000 hours. It's actually, every box is 10 hours, if you want to be specific about it. But these are all the hours in a year. And this is how often the people on average spend in the doctor's office or in the grappling with the medical system, right? So if we're thinking of optimizing people's lives based on that dot, we're not going to win. By comparison, this is the amount of time people spend at work. About 30% of the time, this is the amount of time people spend on the internet, increasingly on mobile. And then there's this. Does anybody want to guess what all this is? Sleep and TV. I just made it all gray because it's basically the same thing. But basically, that's where people live, right? People live in that reality. So we have to map to that reality. We have to measure what's going on in those boxes. So how do we do that? We think about grappling with this real-life experience. We think about finding new ways to measure it, because honestly, it is not captured in RCTs. It is not captured in electronic health records. It is not captured in insurance claims data. It is not captured in all these places that we look as, ooh, that's great data. And they are great data. Those are great data sets. I love those data sets. But they are not the same thing as real life. We need to get to that other level, and we need to think about how we can capture real life experience. So the way we've been thinking about it at my company, Iodine, is in this framework. So if you think about, again, kind of the process by which people go through in a kind of after a post-diagnosis treatment paradigm, the doctor does an assessment. They make the prescription. It's up to the pharmacist to dispense it, and it's up to the patient to take it. And then there's real life. Then there's what happens afterwards. And who owns that? Well, in some sense, everyone owns that. The doctor owns it. The pharmacist kind of owns it. The patient pretty much owns it. But nobody, in essence, owns it, which is to say nobody makes sense of it. That's where real life happens. And if we can grapple with that, if we can figure out how to capture that, we can learn from it. We can learn from it not only to improve the patient's experience, improve the individual experience of that person, the way Joe was talking about, but we can actually learn from it and optimize the system, right? We can feed it back into the inevitable return of that patient back into the system, because they're going to be coming back. Remember the trial and error? Remember the failure rates? They will be back. And we need to learn from why didn't it work. What are the side effects? What were the kind of stresses? Why didn't it fit into the course of their life? We need to think about that, not in a kind of anecdotal way, not waiting for them to come back into the doctor's office and for the doctor to ask that, because frankly, the recall bias is horrible with the patient, and the physician probably doesn't have much time to actually get into the nitty-gritty of what the circumstances were. We need to do better about thinking about that opportunity. This is what I call therapeutic optimization. And if you have a better term for it, please let me know. I know that's a woody term. But it's different. The reason I go to that term as kind of Latin as it is because adherence is not the same thing as adherence. It's bigger than adherence. Adherence is a binary proposition. Is the person putting that pill in their gut, right? That's what Proteus is measuring, and it's an amazing thing to capture, and it's an amazing thing to be on top of. But it's not the same thing as understanding the whole spectrum of the experience and trying to improve the whole spectrum of the problem. Because after all, maybe that's not the right pill for somebody. Maybe that's not the right therapy for somebody. Maybe they shouldn't be getting back surgery, they should be going to physical therapy. But we can only understand that if we know their experience and their life. So how do we get there? Well, the first thing to do is not to measure outcomes. So that's heresy, right? Medicine is all about outcomes. We have to measure outcomes. Outcomes are all that matter. Well, partly I'm thinking about, this kind of translates as patient-reported outcomes, PROs, right? So that's kind of what you may be thinking I'm talking about. I'm not really talking about that. Partly, in part, but really it comes everything before outcomes, because outcomes take too long to happen. If we're measuring outcomes, we are stuck in a paradigm of waiting for something to happen a year from now, 6 months from now, 2 years from now. It takes too long for that patient. It takes too long for medicine to learn that way. We need to get there. We need to capture that. We still need to pay attention to it, but there are other things we need to measure first. What should those be? Well, for this, I go to my friends at Google. So Google has figured this out. They've actually spent billions of dollars figuring this out. They don't think in terms of 2 years. They think in terms of thousandths of a second, right? That's where they get paid. They get paid if it's a difference in search results between 200 thousandths of a second and 400 thousandths of a second. They know how much they're losing in terms of the results popping up on that screen. So what do they measure? They measure these things. They measure happiness, engagement, adoption, retention, and task. Happiness is the consumer, is the person having a good experience? Are they having a positive experience? And you can measure that. You can ask them. You can measure that all sorts of ways. Are they engaged? Do they do things? Are they passive actors, or are they actually doing things when they get to that screen, when they get to that site? Are they adopting? Are they actually signing on as customers? Are they taking some action that represents some commitment? And are they retaining? Are they coming back? Are they returning again and again? Are they customers who you can count on? And finally, will they do something? Will they do something such as click a buy button? Will they do something significant that is measurable? These are all measurable things. Just because it's called heart doesn't mean it's mushy. These are all things that people care about and we can measure, and they come before outcomes. And there's no reason why medicine shouldn't be using the same framework to integrate or to iterate all these other steps before we get to outcomes. Now, this is actually a process that a lot of people are talking about as lean science or agile science, and an amazing kind of new paradigm of scientific research. But it's one that medicine should be leading. This is another reason why it matters. So does anybody know all of these acronyms? I'm going to have to get my cheat sheet out here. I'm sorry. Even I. So it's Affordable Care Act, right? And Center for Medicaid and Medicare Services. But the QHP is Qualified Health Plans. QIS is Quality Improvement Strategy. QRS is Quality Rating System. And the CES is Consumer Experience Surveys. These are all things that are coming down from CMS because of the Affordable Care Act. And all of the Qs mean that somebody is measuring an experience. This is coming down not just from the bottom up, but from the top down. These are changes that are happening that people will get paid differently because of the way they affect people's experiences, consumer experience. This matters to all of us because it's where the money is going in the system, which is amazing. It's happening way faster than I would have thought. This is a real powerful incentive for all of us to care beyond our caring about the patients to begin with. The third principle is to fork the code. So forking the code, I'm again borrowing a kind of meme from technology, in a system like GitHub, right? So let me back up. In software development, there are the kind of open source framework for software development has really become the standard. And places like GitHub are communities where people can contribute the code that they have created and show what they've built. And they contribute there often with the opportunity for other companies to come and take the code, and to adapt it for their own purposes. Facebook does this, Google does this. All major companies these days contribute open source code to GitHub, and it's amazing. It's become kind of a shopping cart that anybody can come to, and it takes years off of development for other companies. Oftentimes, though, what people have to do is they have to adjust the code and tweak it for their own purposes, which is what is called forking. So you take another fork on the code. And this is what medicine needs to do much more of. We are oftentimes stuck in a paradigm in medicine and healthcare where if something has worked someplace else, that's great, but we're going to do it all ourselves from scratch, starting at ground zero, right? We need to do it all over again. We need to validate, which is a good mission. Again, it's all about the outcomes paradigm. That's wonderful and necessary work. But we can take a lot more guidance and initiative and encouragement from what has worked elsewhere and start forking it. We need to think more about a methodology of adapting things that have worked elsewhere and integrating them into our own systems than needing to validate and start from a, that's great, but we'll see what happens when we bring it to our system. More specifically, we need to turn the way this plays out is to turn validated clinical protocols into algorithms. So what you're in essence doing is taking interventions, say, things that have been proven to work, and turning them into code, turning them into software that can be then distributed to not just 1,000 people, but 100,000 or 100 million people. As Joe mentioned, Omada is doing this with diabetes. They've taken the diabetes prevention program, which was a great intervention, kind of classic structure of public health intervention, and they've turned it into a software platform. It's what WellDoc is doing, also Joe mentioned that. It's what Twine Health has done with heart disease, mental health. My company is doing it, Iodine. Lantern is trying to do the same thing with cognitive behavioral therapy. These are all, and there are probably many companies in this room that are doing the same kind of thing. Turning what works in one domain into an algorithm that can transfer to a new domain and reach more people is the future, I believe. It's where all of this is going. And it's all based on the idea that we can bring experiences to people and work them into the algorithms. All of these companies are all about measuring people's experience and responding to it personally and proactively as well as reactively. The trick in kind of moving into this kind of algorithmic era is to think about letting humans do what humans are good at and letting robots do what robots are good at. The robot being the algorithm, all right? The robot being the kind of synthetic version of the protocol. The trick, though, is to, in some ways, make it seem like what the human is doing is done by a computer and make it seem like what is being done by a computer is actually being done by a person. Which is to say we have to kind of personalize the algorithm in a way that makes it seem automatic, but also seems human. And that's not easy. That takes a lot of design thinking, takes a lot of iteration, but it is what we will need to do to actually get through and engage with people as real people. Think about it this way. We like it when Google knows what we're thinking, right? It can anticipate when we do a search, and it anticipates what we're actually looking for. But we don't like it when it can read our mind, right? It creeps us out when we think Google is in our head, but we like it when everything is happening automatically. That's the balance between the robot and the human that we need to kind of transfer. This is, I think, maybe the hardest part of turning all this stuff into code, but it's the part where we're actually going to really engage people as people. So we let the computers do what they're good at, let them do the predictions, let them do the pattern recognition, and then we bring the human into the process where the human needs to be. They make the decisions, they derivate from the recommendation, they need to kind of take the command and control, but the computer is doing all the math, the computer is doing all the algorithmic stuff. The rules of this are pretty straightforward. They boil down to clarity, validity, transparency, and privacy. Clarity means we need to communicate to people as people. We need to speak in human language. We can't speak to them in medicalese. This needs to be valid. It needs to be based on science. It needs to be validated in science. It needs to be transparent. We cannot have these algorithms be entire black boxes. As companies, we need to be very open and allow people to understand how our algorithms are working. We need to have people understand what is actually happening inside the computer. Now, there's a lot of resistance to this. If you think about some of the companies that have been in the news recently with some controversy because they are, in essence, black boxes, it's something we're going to have to navigate. But it is essential that in some level people be able to trust and see how these processes are going. That's the only way we'll authentically capture experience. And we need to make sure about privacy. Now, by privacy, I take a cue here from Tim O'Reilly, one of my other heroes. Tim talks about privacy not as secrecy, but as context and clarity and permission and consent. That's what privacy is. Privacy is knowing what's going to happen and being in control. That is a new kind of framework. It's not putting things behind a locked cabinet, but we need to make sure that people have that sense of privacy and they have that sense of responsibility over their own experience. Ultimately, this all boils down to the willingness and the core impulse to ask people. If we can ask people about their experience, if we can engage them and use microphones, if we can use microphones, then we can start to help people make sense of their experience. And if we use microphones, we can start to help medicine make sense of people's experience and turn that into insights. It sounds easy, right? It should be easier, but I have no doubt that this is the future of medicine. Thank you very much.